Hi, I'm Frank Diamond, the managing editor of Infection Control Today, where we're helping infection preventionists and other healthcare professionals who are helping guide America back to a new normal after the COVID-19 onslaught. With me now is Sharon Ward-Fore, an infection preventionist and consultant. You talked a little bit at the webinar too about the relationship between infection preventionists and environmental services staff. And I guess my question is, how strong of a relationship was that before COVID-19? Did it change because of COVID-19? And will that change continue after COVID-19? I mean, could you say that infection preventionists basically monitored what the EVS team did, almost managed them? I know they probably had their own managers, right. Or was it a different type of relationship?
So it should be a collaborative type of relationship. The hospital I worked at, I was the IP liaison for EVS, and I worked very closely with the managers and the boots on the ground EVS workers cleaning the areas. And I think it's really, really important for IP to be part of the EVS team and EVS to be part of the IP team, because we're so intimately connected. You know, we should be included in discussions about cleaners and disinfectants that are used in various areas of the hospitals. We should be involved in the training just to see, so that we're knowledgeable about how they're trained, so that when we're up on the units rounding and auditing, we know that they're following their own processes. Where I came from, infection prevention monitored the rooms using ATP. We were required to do 2 rooms a month just to make sure that we were following our own cleaning practices. And we had a cutoff point with ATP light units so that we knew that the room was clean or not clean. So besides a visual, we were actually monitoring for level of bioburden too, which is really important. Now, EVS was also doing the same thing, but there's sort of the rub. If that's your department and you're monitoring your own results, there's the potential for bias. I'll just put it that way. So I think when there's another system of checks and balances that's outside of the department, but has that department's best interests in mind, it provides another level of scrutiny that's not biased. So when I would monitor a room and I'd find something wrong, you know, you would just let EVS know and they would come and re-clean the room. But we were also tracking data, and both EVS and IP, and we would notice trends. So then working together, you would kind of dig down into what's happening and figure out if is there retraining that's needed? Are people not using cleaners appropriately? So it is a collaboration. And I think the most successful EVS department has an IP that really enjoys working with EVS.
Do you see, did EVS have to change its approach to cleaning during COVID-19? And I guess when I say approach, I mean, did they have to wear a different PPE than they had historically used? Did they have to stay out of certain rooms? You mentioned in the webinar that CDC is kind of adamant about not having healthcare workers who work with COVID patients, not having them work with non-COVID patients. Right. This is the same dynamic at work with EVS. And again, looking to the future, do you see that dynamic continuing on even after the pandemic has eased a lot?
So I think during COVID-19, EVS, probably the only thing that changed was the volume of room turnovers. And I'm thinking specifically like in an ED, and that they really needed to wear PPE in the general areas as opposed to when they just entered a patient room. So EVS, for example, in an ED would go from bay to bay to bay cleaning. So they would be reusing their PPE just like staff members, probably cleaning more frequently and wearing PPE that maybe they're not the most comfortable with. So that's a point where moving forward, I'm a firm believer in hands-on PPE training, not just a video where you click through some boxes and you watch someone don and doff. So I think training on PPE so that people are comfortable, EVS and everybody else, will probably be something we should do moving forward. In general, I think EVS, their processes won't change. There's all kinds of new disinfectants out there now with maybe quicker dwell times. So maybe that will change, but how they clean won't change. Now, you're right, CDC did recommend that for COVID rooms, if the nurse is in the room, the nurse should do the cleaning. And that'll work when maybe there's a couple of patients. But I think in general, EVS rose to the occasion and went in these rooms and cleaned them when patients were in there. Of course, wearing the appropriate PPE. For facilities that had the luxury of not having to have EVS go in there, I think that's the best case scenario. Just like with our Ebola training, if the nurse is already in the room caring for the patient, you're looking at fewer possibilities of contamination down the road.
You mentioned also when about damage control after COVID-19. I don't talk about damage control to anything physical, but your damage control to the training that IPs have been rendering to their fellow healthcare workers all these years. And then all of a sudden, and you also mentioned in our conversation that CDC kept on changing the guidelines out of necessity. When there's not enough PPE available, you gotta do something. And you also mentioned how IPs have to be flexible. So I'm trying to figure out now, when the pandemic eases, are you in favor of going back to, at least back to the guidelines that were in place before, and maybe even more stringent guidelines, and reserving the flexibility for when the next pandemic strikes?
So I think that's a really good question. I think as IPs, we're going to get some pushback because, you know, staff that put PPE on day in and day out, they get tired of it. And now that we've shown that we can successfully manage patients without it, it's going to be a tough sell to get us back to our regular policies. Now, having said that, I think before we throw everything to the wind, we need to go back to our procedures using PPE if we're able to, without using up our PPE. But in the meantime, I'm hoping someone is looking at data from this period of time where we haven't used that PPE, and we've done environmental sampling, where we've been continuing to do VRE and MRSA surveillance on our patients and finding out, did we have an uptick in these organisms when we weren't using PPE? I'm a big advocate of PPE because I think it does prevent horizontal transmissions. But as I've been reading more and more in the literature, that's one thing we can do. There's a whole bag of tricks out there that we probably should be trying to do a little harder. And one of them is also discontinuing precautions for people. You know, people sometimes are on lifetime precautions for MDROs, but they may not need to be on for MRSA or VRE. There's criteria that can be followed to remove that precaution. And maybe we don't do that enough. So something to look at as we move forward so that we can reserve PPE for our worst case scenarios and maybe spend more time getting patients off of lifetime precautions if there's the ability to do that safely. Does that answer your question?
Yes, you did. Yes, you did. Do you see the IP's role expanding in the sense that healthcare and will want liaisons to government health authorities, private industry is going to want to know what's going on, a hospital system in a city, like a mid-sized city, and a company that makes widgets in the mid-sized city, all of a sudden they're going to want to talk to each other, right? You see IP stepping in and playing that role?
I do. And one area that's been woefully underserved is long-term care. And I think you're going to see a big change in how long-term care is handled. IPs, you know, don't have any oversight over that. Typically in long-term care, they have their pseudo infection control person. Usually it's a nurse that's been assigned that job as well as 100 others. But I think now with this pandemic, there's more eyes on long-term care and congregate facilities, even jails, where we're going to have maybe IP consultants help people figure out what to do. And I don't think you need a full-time IP, but you need someone you can call and say, hey, I think I have a problem. and that person can come in and help guide you through what needs to be done. Someone needs to be keeping track of PPE for these types of facilities. Someone needs to be training staff on the importance of PPE in these facilities. And I just don't think they've had the manpower to do that. And because of it, we've seen tragically that long-term care is where we've seen the majority of deaths. So yeah, I think that there will be a need for IPs to step into areas they haven't touched before. Even the dental industry has risen to the occasion. So there's all kinds of areas that will need some guidance by IPs. So I think there's a lot of opportunities for IPs to stretch their legs a little bit and become knowledgeable in areas outside of acute care facilities.
And finally, speaking now directly to your fellow infection preventionists, give them a heads up of how you think their jobs are going to change in the future, if you think they're going to change that much.
Well, I'm hoping that hospital administrators will realize the value of IPs and of having an infection prevention and control department. Pandemics are one thing we do, but patient safety is first and foremost in an IP's mind. And it touches areas that no one even thinks about. It's construction and renovation. It's EVS. It's food services, the laboratories. So I think IPs are stretched pretty thin in most healthcare settings, and maybe moving forward, systems will realize they need more specialists to be able to handle the many, many areas that IPs touch. And I think a lot of people don't know all the areas that IPs touch. So maybe now they'll understand we're not just the cops with our white gloves, making sure you wash your hands and tie your gown. We do way, way more. And in a pandemic, you'll see how important it is to have good IPs who are able to be flexible and learn and educate, boots on the ground.
Well, we've already seen that, haven't we?
Yes.
Sharon Ward-Fore, one of the newest members of Infection Control Today's Editorial Advisory Board. Thank you so much for stopping by today.
You're welcome. Thank you for having me, Frank. Have a good day.